Good afternoon, everybody, and welcome to our program today. I am John Morelli, the Assistant Vice President of the Acute Care Clinical Institute and Executive Leader of the CommonSpirit Hospital Medicine Clinical Council. And we have here with me today Dr. Tom Frederickson, Assistant Vice President of the Hospital Medicine Operations for the Physician Enterprise. And we are really pleased today to kind of host our first of many quarterly hospital medicine grand rounds. These are really focused on bringing topics that are most important, most relevant to the practice of hospital medicine. And again, we look forward to sharing more of these updates and more of these grand rounds with you every quarter moving forward. Just a little bit about our format today. Today's presentation on hospital medicine updates will be sort of a case-based approach. Case will be presented, and when we reach times during the case, the care of the patients when we're faced with any sort of diagnostic or management decisions, we'll reach out to all of you with poll questions and really to obtain your thoughts on further management. And then we'll support those decisions with a review of the most current literature. So really want to encourage all of you to participate in the poll questions. And just a reminder, responses are anonymous, but I think it would be helpful as we move through the case. So before we get started, just a couple of housekeeping comments. John mentioned already, this is a CME supported program, so information on the access is available on the slide. And the link will be displayed on the chat as well, so you can text the number and obtain the information to claim CME credits. Remember, everybody's going to be on mute during the presentation so that we don't interrupt the presenter. So if you do have any questions during the presentation, please feel free to enter them either in the chat box or the Q&A section, and then we'll try our best to answer as many of those as we can at the end of the presentation. So at this time, I'm going to turn it over to Dr. Frederickson, who is going to introduce our guest speaker for today's Hospital Medicine Grand Rounds.
Thank you so much, Dr. Morelli. It really is my pleasure to introduce you to Dr. Giri Andukuri, who also is my partner, hospital medicine partner in my practice. He's an associate professor at the Creighton University School of Medicine and is an academic hospitalist at our academic medical center, Creighton University Medical Center, Bergen Mercy in Omaha, Nebraska. He obtained his medical degree from Osmania Medical College in India and completed his internal medicine residency at Creighton and a chief residency also here in Omaha at the VA and the University of Nebraska, where he specialized in quality, safety, and high-value care. He is also the director of quality, safety, and high-value care at the Creighton University for Creighton University Graduate Medical Education, and is a core faculty champion for research and QI for our internal medicine residency. He also teaches health system sciences in our medical school. So with that introduction, I'm going to turn the time over to Dr. Andukuri for our presentation today.
Thank you, Dr. Frederickson, and Dr. Morelli for hosting this. Thank you all for joining. So let me just share my screen. Can you all see this and hear me?
Yes, we can.
All righty, thank you. So today, I've decided to do this hospital medicine update, which is for the last 2 years, this being the first of the series of the hospital medicine lectures, I thought this would be a nice way to start this and start having more and more topics as we go through the year. So my goal is to kind of, just like Dr. Morelli mentioned, we'll do a case-based approach and talk about some evidence to support those cases and the answers. So let's get started. Disclosures, I have no financial disclosures. I'm not a subspecialist. There are no COVID-related articles included in this because they constantly change, so it's really hard to keep up. And this is not a journal club. There'll be a lot of articles that we'll be discussing. And I've included some selected and trending inpatient medicine topics from the last few conferences, SHM, et cetera. So that's the goal today. And these are the objectives. I know it's a long list. So what I'll do is I'll just get started, keep going, and I would like to stop at the 10 minutes before the hour. And so that's the plan. These are all inpatient related ID, cardiology, GI, endocrinology, pulmonary, and hematology. So let's get started, okay? All right. So the first case is inpatient ID, a 75-year-old male, African-American male with past medical history of hypertension, hyperlipidemia, is admitted for pyelonephritis and started on ceftriaxone. Urine cultures grew E. coli, which was resistant to fluoroquinolones and trimethoprim sulfa. However, was sensitive to ceftriaxone. Patient improved on day 4, and a decision was made to discharge him on oral antibiotics. What would be the right antibiotic choice for discharge? A, ciprofloxacin, B, cephalexin, C, trimethoprim sulfa, and D, continue IV ceftriaxone as it's a once-a-day dosing and discharge the patient. All right, let's see. All right, so that's pretty good. There's I mean, that's what I was expecting because that's what we do in our practice. So let's see what the answer is. So this is the paper that was published in 2020, and in JAMA. This is oral beta-lactam antibiotics versus fluoroquinolones or trimethoprim sulfa for definitive treatment of enterobacterial bacteremia from a urine source. So this was a retrospective cohort study, was conducted from 2007 to 2015 at 114 VA hospitals. Average age was 71 and 91% was male, as expected of the VA population. Beta-lactam group had greater comorbid conditions, and antibiotics used were augmentin, cephalexin, cefpodoxime, which was about 25% of the treatment there, and ciprofloxacin was about 78% in the fluoroquinolone trimethoprim group. So patients were treated for a total of 14 days with 4 days of IV antibiotics in case of fluoroquinolones and 5 days of IV antibiotics in case of beta-lactam group. So if you look at the study, there were about 10,000 patients they started off with, but by the end, before they got down to the numbers, there were about 1,000 patients. So 955 received oral beta-lactams, and just over 3,000 patients received oral fluoroquinolones or trimethoprim sulfa. So if you look at the outcomes here, the primary outcome was to see if there's any difference, and doesn't look like there's any difference in the primary outcome of treatment, essentially. Is there any difference in mortality? No, there isn't. There's no difference in recurrent bacteremia either, if you look at the results there. So similar results for recurrent bacteremia after 90 days as well. The strength of this study is a large cohort study. If you see, as you see those numbers, the weakness, obviously, it's a retrospective observational study, mostly in older males, and less than 20% of these patients were ICU patients. And this may not have captured non-VA readmissions because some of these patients actually go out to the community as well. But regardless, I think this gives us a better idea of what antibiotics we should be treating these patients with. So the answer is this patient can safely be discharged on an oral beta-lactam antibiotic for a total of 14-day course because there's no difference as such. So it's safe to do so. There is some evidence that patients who are hemodynamically stable can be discharged even sooner. So remember, in this case, it was like at least 4 days or 5 days. So we can possibly discharge within, after 3 days of IV antibiotics. However, it's strongly advised to consult infectious diseases if patient has multi-drug resistant bacteremia or ESBL. So this, I was discussing this with our infectious disease colleagues, and that's what they have recommended, that we could probably discharge sooner because we are hospitalists, and that's what we always talk about and ask for. But also, if it is a complicated patient, they would like to be on there. We have a very good antibiotic stewardship program here, and they are very, very proactive, and they do call us and give us suggestions. So we do get some help in that regard. So the next case is inpatient ID / pulmonary. So this is, again, the same patient. And what we are now seeing is the patient improved on day 4 A decision was made to discharge him on oral cephalosporin at 9:30 a.m., just like we discussed. That should be the right choice. And us being a hospitalist, we were trying to discharge this patient early. And at 9:45 a.m., a nurse called stating that the patient is complaining of some shortness of breath, and pulse ox is 92%, which is new. Incident spirometry was ordered, considering the lack of activity for the last few days. So now the question is, do you want to obtain an ABG? So the answers are yes, because it may get worse. Yes, because African Americans can have falsely elevated pulse oximetry. No, patient is ready for discharge. No, because pulse oximetry is within normal limits, I should say. All right, let's see what the results are. Yes, because it may get worse, and the no, pulse oximetry within normal limits. Okay, I don't think we got the right answer, but so there's something to learn here, I guess. So racial bias and reproducibility in pulse oximetry among medical and surgical inpatients in general care in VA from 2013 to 2019. It's a multi-center retrospective cohort study, was published in BMJ in 2022. So the objectives of this study was to evaluate measurement discrepancies by race between pulse oximetry and arterial oxygen saturation, as measured in arterial blood gas among inpatients not in intensive care. So that's important to note. The design was a multi-center retrospective cohort study using EMR from general care, adult, medical, and surgical patients in the VA. The main outcomes were occult hypoxemia, defined as arterial blood oxygen saturations of less than 88%, despite a pulse oximetry reading of more than 92%. So just like our patient here had a 92%, greater than or equal to, I should say. And whether the rates of occult hypoxemia varied by race and ethnic origin. So if you look at the study, this is a large study, lots of patients, but when we got down to the paired measurements between patient days for Black and white patients only, it was about 28,000 patients that were compared, if you see on the right there. So the results, as you see in the illustration there, on the x-axis, you see the probability of occult hypoxemia, and on the y-axis is basically the O2 pulse oximetry measurements from starting from obviously 92% until 100% at 2-minute intervals, 5-minute interval, and 10-minute intervals. And if you see the African American patients, all the way from 92% 92% pulse ox reading to 100% pulse ox reading, they always have occult hypoxemia. If you see the results, adjusted probability of occult hypoxemia was 4% higher in African American patients than the white patients. And African American patients had a higher incidence of subsequent occult hypoxemia, even if initially it was absent. So as they measured, if initially it showed 92%, even though the O2 sats were appropriate and over 88%, but eventually they observed that it actually went down. So something to keep in mind, especially with more and more cases that we see, especially with COVID, et cetera. It's important to keep this in mind. There were some differences in other races as well, in Hispanics and Asians, et cetera. There was difference, but not enough, not as high as the African American population. So just to keep in mind. So the next case that I have is inpatient ID pulmonary again, a 65-year-old African American male with past medical history of hypertension, hyperlipidemia, diabetes mellitus, admitted for acute CVA with hemiparesis on the right side and left-sided facial droop, and being discharged to acute rehab for PTOT and speech therapy. He was cleared for nectar-thick liquid diet. At 9:45 a.m., nurse calls stating that the patient is complaining of some shortness of breath and pulse oximetry is 90%, which is new. The nurse also mentions patient was having breakfast and choked on his Jello. ABG revealed SaO2 of 87% and mild respiratory alkalosis. He's placed on 4 liters per minute of O2 to keep his pulse oximetry over 96% via nasal cannula. Remember, this is an African-American patient, so we want to keep it higher. CBC revealed a white count of 13,000. Aspiration is confirmed on chest X-ray. What is the next step? A, initiate peptazo. B, initiate vancomycin in unison. C, no antibiotics. And D, clindamycin. Okay, I think all the hospitals are up to date on this one. Very good, guys. So no antibiotics is the right answer. Association of early antibiotic therapy, in adult mild to moderate acute aspiration pneumonitis, a cohort study. So this one, patients with aspiration pneumonitis often receive empiric antibiotic therapy despite it being due to a non-infectious inflammatory response. In this study, it was decided to study the benefits of early antibiotic therapy in patients with suspected aspiration pneumonitis in acute care hospital setting. So I was talking to some of our pulmonary colleagues and ICU docs, and they mentioned that even though this is always the right answer, just like all of you answered, no antibiotics. But they routinely see that these patients actually become sick and they get a pneumonia eventually. So that is something that was noted here too. So the key word is early antibiotic or not. So that's what we need to kind of so wait and watch is what we're trying to do here. So this was again a retrospective study. It was done in Japan. So it may not be applicable to our population completely, but good study nonetheless. So most were adults over 18 years admitted with a diagnosis of aspiration pneumonitis to general internal medicine and emergency medicine between 2008 and 2019. A diagnosis of aspiration pneumonitis was defined as a documented macroaspiration event, and a chest radiograph demonstrated new radiographic infiltrates. So there were infiltrates on the chest X-ray. So the main measures were early antibiotic treatment group and no or late antibiotic treatment group, depending on whether they receive antibiotics therapy for respiratory bacterial pathogens within 8 hours of arrival. The primary outcome was in-hospital all-cause mortality, and secondary outcomes included length of hospital stay, antibiotic-free days, duration of fever, readmission within 1 month, and incidence of compliance. So if you look at this, in the no or late treatment group, there were 52 participants by the end, and then in the early antibiotic group, there were 94. The outcomes in hospital mortality, if you look at it, early was 6.4, late no or antibiotic or late antibiotic was 4.1, which was not significant. And antibiotic-free days, however, was significant. So if you started late or no antibiotics, the antibiotic-free days were about 9.1 days. So it was significant compared to the 5.3 days with early antibiotics. These antibiotic-free days I'm talking about. And then length of stay, again, in early was actually 9 days, and no or late antibiotics was 7 days. So there were, so that was less than 0.05 as well. So it's a good study. And I think you all answered it right anyway. So good going, guys. The next one is inpatient ID and pulmonary. Again, it's the same patient. So we have no antibiotics were started. However, just like we, some of my pulmonary colleagues mentioned, on day 3, the patient started having increasing shortness of breath with a respiratory rate of 22 and 6 liters via nasal cannula to keep SpO2 over 94%. Cough, fever, elevated white count of 15,000, blood pressure 110 over 65, chest X-ray revealed right middle lobe pneumonia. Blood cultures were sent before starting empiric antibiotics for hospital-acquired pneumonia / severe sepsis. Coverage with for MRSA and Pseudomonas was decided upon. So the decision was made to start vancomycin and cefepime. Which one should be given first? Vancomycin, cefepime, both simultaneously, or doesn't matter? Okay. Yeah, partially right. So let's look at this evidence here. So administration of beta-lactam or vancomycin as the first dose of antibiotic therapy improves over vancomycin, improves survival in patients with bloodstream infections. So this was published in Clinical Infectious Disease in 2022. The background here is to determine if sequence of administration of first dose of antibiotic therapy, beta-lactam or vancomycin, if both are deemed necessary and cannot be administered simultaneously, which one should we give first? So does it impact mortality for patients with bloodstream infections? So the methods, multi-center observational study, patients were over 13 years with bloodstream infections to evaluate association of sequence of antibiotic administration with 7-day mortality using inverse probability of treatment weighting, incorporating propensity score matching here. So there were about 3,376 eligible patients, 2,685 received beta-lactams and 691 received vancomycin as an initial antibiotic. So the results are in front of you. So beta-lactam versus vancomycin, the 48-hour mortality, in fact, was the odds ratio is 0.45, it's almost like 0.5 if you really think about it. So 50% benefit of the 48-hour mortality, and even the 7-day mortality is the same. So it's pretty evident that you should give the beta-lactam first if you can do so. So the question arises, what if it's MRSA? So they did look at that as well. Mortality was not lower in MRSA bacteremia when vancomycin was given first. And this is something I discussed with our infectious disease colleagues. And they mentioned, the reason for this, they think, and it's kind of described in the paper as well, is because of the gram-negative bacteremia that the beta-lactams affect. That kind of reduces the endotoxin production there, because obviously we are attacking those bacteria sooner than later. So in case of gram-positive cocci, it doesn't really matter which we are trying to treat with vancomycin, because they don't produce endotoxin. So and as you know, gram-negative sepsis is far more dangerous compared to gram-positive. So that's the reason why apparently beta-lactam actually should be given first and works faster and better and reduces mortality in this case. Inpatient medicine and infectious diseases, a 55-year-old female smoker with past medical history of hypertension, hyperlipidemia, diabetes on dapagliflozin, came in with fever, cough, shortness of breath, and was noted to have left upper lobe infiltrate. And she was started on intravenous ceftriaxone and azithromycin for community-acquired pneumonia. Initial blood cultures grew strep pneumoniae. Repeat blood cultures on day 3 of therapy revealed no growth, which resulted on day 4, and patient's fever also improved. What antibiotic would you discharge this patient on? Levofloxacin, azithromycin, high-dose amoxicillin clavulanate, or continue IV ceftriaxone? All right. Let's see. High-dose amoxicillin clavulanate. Very good. So that's the right answer. Let's look at the evidence here. So fluoroquinolone versus beta-lactam oral step-down therapy for uncomplicated streptococcal bloodstream infections. This is very similar to the first study that we looked at. So this is a multi-center retrospective cohort study, analyzed adult patients who completed therapy with an oral fluoroquinolone or beta-lactam with at least one blood culture positive for strep species. So strep species. And in fact, 34% of these strep species were in this study strep pneumo. The primary outcome was clinical success defined as lack of all-cause mortality, recurrent bloodstream infections with same organism, and infection-related readmissions at 90 days. So the mean age was 64, 55% for female. Median time to oral antibiotics was 5.7 days. Total treatment duration was 14 days. And as I mentioned, strep pneumo was about 34% of the blood cultures there. So if you look at it, the clinical success for fluoroquinolone was 92%, beta-lactam was 93%. So they were both equally effective in a way. And then mortality, if you really look at mortality, readmission, and recurrent bloodstream infections, there was no difference. So either you use fluoroquinolones or beta-lactam at discharge, it didn't matter. And more, we are seeing that, we are not trying to send people on fluoroquinolones for obvious reasons. And we'll actually talk about that in a little bit here too, because of a lot of, resistance, complications, etc. So, but then the oral step-down therapy, if it was less than 3 days, then within 3 days, that is, then there was an increased odds of clinical failure. Odds ratio was 5.2. So our patient hence can be discharged on high dose beta-lactam. High dose is key, such as Augmentin, which is amoxiclav, of 875, 125, amoxicillin, ceftriaxone, cefpodoxime, doesnn't matter. I mean, in any one of those, etc. After 4 days of IV treatment for a total of 14-day treatment. So this is what I was talking about a little bit ago. So there was a JAMA study in 2020, which was looking at association of fluoroquinolones with risk of aortic aneurysm and aortic dissection. This is highlighted a lot and talked about a lot. But this study, if you look at the numbers, the N in this cohort study, the patients with pneumonia were about 279,000, and urinary tract infection were 948,000. And those receiving fluoroquinolones for pneumonia had an increased rate of aortic aneurysm and aortic dissection versus those receiving azithromycin. So if you really look at the numbers closely, though, it's not much of a difference. It's 0.03% to 0.01%. In comparison of fluoroquinolones versus combined trimethoprim sulfamethoxazole for UTI, there was no increased risk noted. So the findings of this study suggest that given the low rates of aortic aneurysm and aortic dissection across cohorts, the benefits of choosing fluoroquinolones when appropriate may outweigh the small potential increased risk of aortic aneurysms or dissection. I know some of you may also resist using fluoroquinolones for the sake of obviously the resistance, but also you might mention the tendinitis and any like mostly cartilage-based side effects of fluoroquinolones. And this is exactly why there's more aortic aneurysm and dissection in this population too. So something to keep in mind, but for short courses, I've looked at some studies, for short courses, it doesn't really matter. It's usually if you're putting these patients for a longer term is when you need to be really worried about it. But if you can avoid it, you should probably do that. So the next one is inpatient GI. While on night float, a 55-year-old female smoker with past medical history of hypertension, hyperlipidemia, HFrEF with EF of 40%, diabetes on metformin and dapagliflozin came in with a syncopal episode, coffee ground emesis, melena since the last 2 days, and hypotension with a blood pressure of 90/65 and heart rates of 110. She has been taking NSAIDs after a recent injury from a fall on ice. Hemoglobin is 7.5 grams per deciliter. Last known hemoglobin was 10.5 a few weeks ago. The Glasgow Blatchford score, GB score, indicated high risk for further bleeding or death. How soon do you want GI to perform EGD? Urgently within 90 minutes, ASAP within 6 hours, within 24 hours. It's okay to wait until 48 hours. Okay, within 24 hours. That is, I believe, the right answer. So let's take a look at the evidence here. So timing of endoscopy for acute upper gastrointestinal bleeding. So that's the New England Journal paper from 2020, April 2020. So this was a randomized control to evaluate differences between urgent EGD within 6 hours versus early EGD within 24 hours. So the average age in this study was 70, and 63% were male. Just about 3% had variceal bleed. So these were the sicker patients. So the total N was 598 adult inpatients with upper GI bleed. high risk for further further bleeding or death based on the GB score of greater than 12. They were divided into urgent and early. Urgent meant less than 6 hours. Early meant less than 24 hours according to the study. I mean, in reality, that wasn't the case. And then the endpoints of the 30 days were death from any cause, further bleeding, and hospital length of stay is what they looked at. So the mean time from presentation to endoscopy was about 9.9 hours, plus or minus 6. So even in the urgent group, so it was not really 6 hours. And in the early endoscopy group, it was 24 hours, plus or minus 9 hours there. So even that was more than 24 hours, as you can see. But regardless, the outcomes, if you see, the bleeding ulcers in urgent were actually were seen more, so they were 19%, and in the early endoscopy, they sorry, 19 in numbers, and 12 in the case of early, and then these are the bleeding ulcers, and endoscopic treatment obviously was performed more in the urgent compared to the early, and there is obviously there's it was significant, and 30-day mortality was 8.9%, to early was 6.6. There was no difference there. Further bleeding there was no difference there, and hospital length of stay, there was no difference there either. So the advantage of urgent endoscopy was so there was increased identification of bleeding ulcers and increase in endoscopic treatment. But the mortality, further bleeding, and hospital length of stay, it didn't matter, which were the primary endpoints of the study. So, so essentially, we could wait. But one caveat, though, that when I was talking to our GI colleagues, they mentioned that these studies, they don't include the brisk bleeders, those variceal bleeders, which is important to kind of know. So if you really feel that the patient is getting worse really, really quickly, it's important to consult them and let them come and evaluate the patient, and they can decide if the patient needs endoscopy or the patient needs either even surgery or interventional radiology to come and see the patient as well. So they should be the ones making that decision, not us. I mean, we should consult, but we shouldn't be pushing for the urgent endoscopy in the middle of the night because there's no evidence to do that. Inpatient endocrine, while on night float, the same patient essentially. So the patient was hydrated and and serial HNH were checked. GI performed EGD after patient was stable within 24 hours, just as we saw the evidence, and noted a gastric ulcer. Patient was stabilized, and however, nurse called stating she is nauseous. The patient, that is, abdominal pain and tachypnea and shortness of breath. Repeat labs revealed mild leukocytosis, normal glucose, however, anion gap metabolic acidosis. Serum and urine ketones were elevated. In fact, urine glucose was also elevated. So what is the diagnosis? Starvation ketosis, alcohol-induced ketosis, euglycemic decay, or frank decay. That's euglycemic decay. Very good, very good. So you guys were, and I was mentioning the daffodil flows, and you were kind of paying attention. That's good. So let's see. So so this is not new. There's a lot of benefits of SGLT2, as you know, in CKD and heart failure, and as part of goal-directed therapy now, and we're trying to get everybody on SGLT2. So it's important to know what side effects can happen from it. I was kind of mentioning this in a previous talk as well, that when I was a resident, we were talking about adding aspirin, beta blockers, and statins to water. So this is another one of those new medications which has got multiple advantages, and it can be possibly added to water. But looks like not so fast, huh? So let's take a look at why. So ANLs actually published a paper in 2020 by Duros et al. So here they compared DPP4 inhibitors to SGLT2, and they in this particular study, the average age was 64, 41% were female. About 60% of the group had diabetes mellitus for more than 10 years. And they noted that SGLT2 inhibitors had higher incidence of DKA per 1,000 person years, about 2 compared to 0.75 in case of DPP4s. So the risk of DKA was greater amongst patients with without insulin use. It's something that's very, very, very important to kind of understand why. And also something else to note here is canagliflozin was the worst culprit in this, DAPA being the least dangerous in terms of causing euglycemic DKA. So the reason it turns out that when you're on SGLT2, you're not on insulin, what's happening is you're depleting all your glucose and peeing it off, and you essentially create a state where a hypoglycemic state, and there's no insulin production because the body thinks it's hypoglycemic, hence the euglycemic DKA. So that's the reason for it. There was another study in a Canadian journal of diabetes, which kind of showed similar results there. SGLT2 inhibitors had a 2.5-fold higher risk of DKA with a relative risk of 2.5. The cohort studies showed 1.7-fold higher rate of DKA compared with other diabetes medications. So it's very important to kind of know this and keep this in the back of your mind, especially if it's a type 1 diabetic, and you cannot use this singly. All right, inpatient cardiology and nephrology. 85-year-old male with history of hypertension, hyperlipidemia, coronary artery disease, HFrEF with EF of 40%, and ESRD on HD hemodialysis, came in with palpitations and shortness of breath. He was noted to have AFib with RVR. His CHA2DS2-VASc was 5 and no history of bleeding. His rates were controlled. What anticoagulation should be started on this patient? Warfarin, no anticoagulation, apixaban, 5 milligrams BID, or dabigatran. Fantastic. That's the answer. I know this is not new information, but I'm just wanted to kind of, like I said, I'm including almost like 2 years worth of studies. So some of you might have seen this evidence already. But at any rate, this study is actually a network meta-analysis for oral anticoagulation for patients on atrial fibrillation on long-term dialysis. So there was 16 observational studies comparing safety and efficacy of DOACs and warfarin to no anticoagulation. And the outcomes, as you can see, were stroke and or systemic embolism was the one of the outcomes. All-cause mortality and major bleeding were compared. So there was no difference between no anticoagulation and warfarin and apixaban in terms of stroke or systemic embolism. And all-cause mortality, more in no anticoagulation and apixaban 2.5 warfarin group as compared to apixaban 5 milligrams. So the mortality was higher compared to apixaban 5. And then major bleeding, there was no difference between apixaban and no anticoagulation. So essentially, you use it or not, there was no difference between major bleeding. And apixaban to no anticoagulation had decreased bleeding risk compared to warfarin and other DOACs. And dabigatran had the highest risk of bleeding compared to warfarin. So do not use dabigatran in ESRD patients. So this is a large meta-analysis, but there was a lot of heterogeneity. So no conclusions can be made given small number of studies with DOACs in general here. I mean, there were very few studies with DOACs. But so it's safe to say the only safe DOAC is apixaban 5 milligrams BID if needed to be used. So just another study I just wanted to kind of mention here is adverse events associated with addition of aspirin to direct DOACs without a clear indication. So, we sometimes see these patients coming in with DOACs and aspirin. It's important to kind of get these patients, some of these patients off. So among patients taking DOACs for AFib or BTE, what are the outcomes following concurrent, ASA or aspirin use? So in this registry-based cohort study, 1/3 of the patients with DOACs were also taking aspirin. So comparing two propensity score matched groups of 1,047 patients without a history of heart valve replacement or recent acute coronary syndrome, that's important to note. Patients treated with combination therapy had significant higher rates of bleeding and hospitalizations for bleeding. So there was no significant difference in the thrombosis rate. So it's important that we need to get these patients off of aspirin whenever possible. Again, in patient GI, a 57-year-old male, past medical history of alcohol use, hypertension, hyperlipidemia, admitted for epigastric pain, nausea, and vomiting. His heart rate is 100, blood pressure is 140 or 85. Respiratory rate is 20, elevated lipase of 2,200. White count is 15,000 with confirmed diagnosis of pancreatitis on CT. So there's so this patient had pancreatitis because it's a CT diagnosis. So plan is made to give intravenous morphine for pain and start on a diet as tolerated, because the current guidelines are asking us to start diet as soon as tolerated by the patient. And also the question here is, what fluid rate should we start this patient on? 200 cc's an hour after 1.5 liter bolus, 100 cc's an hour after no bolus, 200 cc's an hour, 100 cc's an hour after 1.5 liter bolus. And this is assuming a 70 kilogram patient. All right. So almost 50%. That's good. So it looks like some of you have already reviewed this literature, but for this, the rest of the half, aggressive or moderate fluid resuscitation in acute pancreatitis. So this was a 2022 NEJM paper. This was an open label randomized trial in 18 sites comparing aggressive hydration to moderate hydration in mild to moderate pancreatitis. The methods, a total 249 patients, approximately 60% had biliary pancreatitis, and approximately 25 SIRS patients in there. No organ failure on admission. Aggressive fluid camp was 20 cc's per kilogram bolus, followed by 3 mils per kilogram per hour. And then moderate fluids was 1.5 mils per kilogram per hour. There was no bolus. But they were given a small bolus of 10 mils per kilogram per hour if they were noted to be hypovolemic on reassessment at 12, 24, 48, and 72 hours. So there was a small study, it was an open label study, and it was stopped during the first interim analysis due to increased trend towards more respiratory failure, organ failure, and necrotizing pancreatitis and others. These are the results. As you can see, the total fluid after 48 hours was more in case of this aggressive arm, and the moderate arm had 5.5 liters. And moderate to severe disease was 22.1 in case of aggressive, and moderate had only 17.3. This was not statistically significant, but you can see that we had more severe disease in aggressive arm. And fluid overload was actually statistically significant, and that's obviously obvious reason. So we're having to give them more diuresis later, etc. The length of stay was 6 days in case of aggressive arm, and moderate arm actually was 5 days. And this again was not statistically significant. But and looks like the way they observed in this the trend of increased organ failure and increased necrotizing pancreatitis. In fact, I had 2 patients since I reviewed this. And both the patients, even before I came on service, the patients had gotten, the 200 cc per hour with the additional bolus, and both had necrotizing pancreatitis. So, I mean, it's N of 2. But my point is, it looks like the trend is to go lower in terms of giving the fluids. So 100 cc's per hour is a good way to start these patients after maybe a small bolus based on hypovolemia. Balanced crystalloids versus saline in critically ill adults. So this was a New England Journal study that came. So if you all remember, we had almost started doing only crystalloids in case of severe sepsis based on the current surviving sepsis guidelines. But more and more studies are coming saying that they went back and looked at it, and they're saying that there's not much of a difference. So start whatever is available. There's a slight advantage of having crystalloids, starting crystalloids for boluses in sepsis patients. I'm not going to go deep into this. I just want to include some of these in here. And again, there's some new studies mentioning that a repeat bolus when you're doing maybe a third of a liter bolus is enough instead of trying to do a full liter too. So there's some other studies as well. I just wanted to kind of throw it in there. There's this up and coming. There are more and more studies coming this year, so I didn't include them in here. But just to keep in mind, and still crystalloids are the way to go with slight advantage, I guess. But all the talk about crystalloids, normal saline can cause hyperchloremic acidosis, hence may not be the right and can increase length of stay, and critical care patients who are already sometimes acidotic, etc. It may not be true given the newer studies. So in fact, surviving sepsis actually decreased that as a weak recommendation now. So you can choose either or, preferably crystallized, I guess, still. Again, I just wanted to mention this, kind of reiterate that. So the first study that changed the guidelines essentially was the one in March of 2018, where they said the use of balanced crystalloids for intravenous fluid administration resulted in a lower rate of composite outcome of death from any cause, new renal replacement therapy, or persistent renal dysfunction than the use of saline. This was the 2018 study in NEJM. But this is another study that I just wanted to kind of share. That if you really look at the Kaplan-Meier curve on this newer study, which came in 22, there was not much of a difference. Just another study I wanted to kind of bring to your attention. This is about DKA and how we treat DKA. So is balanced electrolyte solutions versus acetonic saline in adult patients with diabetic ketoacidosis, systematic review and meta-analysis. So this, in this systematic review, they just had three meta-analysis, three RCTs that they chose. So it is not that big of a study that way. But then they have noted that, in this particular study, when the heterogeneity was actually low, this study favors balanced electrolyte solution. So even in DKA patients, I know most of our guidelines and our order sets have normal saline in it. I think there's a slight difference between these two, and it's better, in fact, to use crystalloids. So it looks like more and more crystalloids, less and less fluid is the trend that we are seeing in treating whenever we give a lot of fluids and boluses. So here, if you really look at the results there, the use of balanced electrolyte solutions among patients with moderate to severe DKA is associated with faster, which is about 4 hours faster resolution compared to acetonic saline in DKA. So 4 hours is significant time. Sometimes our patients come out of the ICU, within a day anyway. So that's an advantage, and that's 4 hours sooner that you can discharge the patient possibly. So it's important to note this. There's in fact some other studies coming pretty soon here, a couple more studies in fact, which are bigger randomized controlled trials. So more to come on this one, but just to keep in mind. The next one is in patient hematology. I think I'm kind of running out of time, so I'll just finish the thought on this one real quick, and then we'll go from there. So this is the same case. So this is the same patient with epigastric pain and pancreatitis. Patient was also started on IV fluids at moderate rates at 1.5 cc's, just like we learned right now. The intern was wondering which medication to use for DVT prophylaxis. All right. Good. So I guess I don't have to spend a lot of time on this one. So there's a network meta-analysis that they did. And just like you guys said, an intermediate dose, low molecular weight heparin is the best in terms of benefit versus harm. But the interesting fact here is none had any mortality benefit versus placebo, and low molecular weight heparin reduced VT versus placebo, and that's kind of a given. And some of us actually give heparin, unfractionated heparin, 5,000 TID. So looks like that had worse profile. So maybe going to 5,000 BID would be a good way to do it if you have to give that. So that's where I'll end. I'll stop here because I guess I'm running out of time. I just wanted to take it slow and not rush to finish it. So
no, we appreciate that, Dr. Andukuri. Thank you very much for your presentation. And want to remind everyone that there'll be a recording of this, and so you'll be able to, if other team members want to listen and participate in this enlightening CME event, they are welcome to. So we'll make sure. I think that takes about 2 or 3 weeks to get prepared and sent out. We'll make sure that it gets sent out. We have maybe time for 1 or 2 questions. If anyone wants to put a question in the Q&A before we wrap up.
So I think I saw, I mean, I heard briefly about your question here, and then there's a chat box question too, risk factors for SGLT2 causing DKA. I'm no expert, so I should be careful. My wife would have been a better person to answer this because she's an endocrinologist. That said, you know, we are using more and more of this. This is a very safe medication, so there is no I mean, obviously it is given in patients who have heart failure, patients who have kidney disease and CKD, etc. So I don't know if there is anybody in the group who can comment on, because I know there are some specialists here too, I saw.
I guess my point would be that some of these, the general point is, and not that I know it's not the great thing about being a hospitalist is suddenly you have to know everything, right? So you know, I always get nervous with new medications that, you know, people start really pushing hard for, but then you get that post-marketing data when thousands and thousands and millions of patients, and suddenly we start seeing side effects.
Yes.
So it's not surprising to me that we're going to start. We may see more, and you know, I guess the question is keep our eye out for those case reports and think of these things happen. And I would argue that's not uncommon with the new medication, that these things start to pop up. I don't know, Tom and John, you've probably, you know, how many new medications have we heard? People got very excited. We should be giving it to everybody, and then suddenly, you know, a couple of years into this, we're hearing and seeing cases all around.
Yeah, I think one of the things to keep in mind is the fact that the new heart failure guidelines that were just released really promoted the use of the SGLT2 inhibitors, both for HFrEF and for those with preservative, you know, ejection fractions, well, with various levels of support, but strongly recommended with those with a reduced ejection fraction. So if we start adopting these guidelines, as you mentioned, we may start seeing some more side effects from these drugs moving forward.
Yeah, new drugs make me nervous. I'm just an old school guy, you know me. I still prescribe hydrochlorothiazide. You know, when I don't know, you know, you get nervous when you start hearing this more and more. But that's just my old methodology here.
So the most important thing is make sure that they're on insulin. So as long as there's some insulin, this doesn't happen. So the decay doesn't happen. So it doesn't cause that cascade of ketogenesis. So.
Well, and that's consistent with the guideline that we shouldn't be starting just sliding scale on these patients.
Exactly.
Basal, right?
That's right.
Well,
Okay.
Amazing review. Thank you. I'm overwhelmed though. I gotta, you know, I gotta watch it 2 or 3 times. It was a lot of information.
Yeah, I actually went through the whole thing earlier in an earlier presentation, and it was so fast. But I just didn't want to do that today. I mean, it was still pretty fast, but I just.
No, it was great. It was excellent. Thank you.
Yeah.
It's a whirlwind tour, and we appreciate it, Dr. Andukuri.
Thank you so much.
Well, I think that wraps up our grand rounds, and just another plug. We're going to be doing this quarterly. watch out. Watch out for the invitations, and we have some very good topics lined up, but also an invitation to the group. If anyone on the group has presenters that you think would be very good for this forum, or topics that you think would be good for this forum, let Dr. Morelli or myself know, and we will move forward. Thank you, everyone. And we appreciate, once again, Dr. Andukuri for sharing his knowledge with us.
Thank you so much for the opportunity. Thanks.
Take care.